High blood pressure is a silent, persistent physical force. Every second, it exerts constant pressure against the delicate inner walls of the arteries, slowly causing cumulative damage without triggering a single outward symptom. Over the next 6 minutes, we are going to build a complete, actionable nursing care plan for hypertension, using proven clinical strategies developed by the nursing team at Arka Anugraha Hospital. Before we begin, gather your prerequisites: a patient's physical medical chart, basic assessment tools, and a blank care plan template like the one shown here. This personalized roadmap provides the specific navigation required to move a high-risk patient towards stable health, a level of precision that a generic checklist cannot provide. Step 1 is the baseline assessment. Before making care decisions, we must gather comprehensive data to understand exactly how the patient's body is currently functioning. Our checklist starts with vital signs: blood pressure in both arms, resting heart rate, and temperature. Next is a physical exam, checking heart sounds, BMI, and peripheral pulses for fluid retention. Finally, patient history, documenting salt intake, stress levels, and medication consistency. Completing this multifaceted assessment gives us the full picture. It prevents us from treating the disease blindly and ensures our plan targets the specific realities of the whole patient. With our baseline data gathered, Step 2 requires interpreting those numbers to identify the core problem. This illustrates a crucial distinction. A medical diagnosis identifies the disease itself, hypertension. A nursing diagnosis identifies the specific day-to-day problems the patient faces because of that disease. For a hypertensive patient, valid nursing diagnoses might include risk for decreased cardiac output, ineffective health maintenance, or activity intolerance due to weakness. Defining the exact nursing diagnosis dictates everything that follows. It allows us to create targeted, individualized interventions later in the plan, rather than guessing. Step 3 takes our defined nursing diagnosis and turns it into a concrete, measurable target. We use the SMART framework: specific, measurable, achievable, relevant, and time-bound. For example, maintaining blood pressure below 140/90 within 3 months. The exact numbers make it measurable, and the 3 months make it time-bound. We can also set behavioral SMART goals. For instance, instructing the patient to walk for 20 minutes, 5 days a week for the next month. The most common failure point in care planning is writing vague goals like "the patient will get better." Without strict deadlines or specific metrics, progress is impossible to track. Writing rigid SMART goals provides an objective standard. It is the only way a nurse can definitively determine whether their interventions are actually succeeding. With our target set, Step 4 moves us into action. We build our interventions on 4 core pillars for hypertension management. The first pillar is medication. We organize simple pill schedules, often using multi-compartment organizers like the one shown here, and explicitly instruct patients to take a missed dose as soon as they remember, but to never double up. The second pillar is diet. We teach the DASH diet by focusing on highly specific actions, like deliberately reducing daily salt intake and adding at least 1 fresh vegetable to their routine every single day. The third pillar is physical activity. We prescribe slow, steady movements, like basic yoga, to safely elevate the heart rate while monitoring for breathlessness. The fourth pillar is stress reduction. We work directly with the patient to identify their psychological triggers and introduce deep breathing or meditation techniques. Combining all 4 distinct pillars into a single care plan attacks hypertension from every angle. Over time, these structural lifestyle changes significantly reduce the patient's reliance on medication alone. Step 5 is the evaluation phase, where we measure the actual success of the applied interventions. The timeline for evaluation depends heavily on the setting. In a hospital, we check blood pressure every 4 hours. For outpatients at home, we require daily tracking logs to spot long-term trends. To evaluate the patient's knowledge, we rely on the teach-back method. We ask them to verbally explain their medication schedule and dietary limits back to us to confirm they understand. This infographic illustrates the real-world barriers that frequently derail care plans. We watch out for medication side effects, financial barriers to affording healthy food, and a severe lack of motivation, which is common since hypertension rarely presents physical symptoms. Evaluating a care plan is an ongoing process. It requires actively troubleshooting real-world lifestyle obstacles rather than just recording their blood pressure numbers and walking away. Take a look at this completed document. Notice the logical flow. The baseline data we gathered in the assessment feeds directly into our diagnosis, which shapes our SMART goals, defines our specific interventions, and concludes with our evaluation block. While hypertension is rarely cured entirely, strict adherence to this care plan and consistent lifestyle adjustments significantly reduces the need for heavy, long-term medication. For more expert healthcare resources, clinical case studies, and nursing guides, visit Arka Anugraha Hospital's website at arka.health. A structured care plan converts the clinical complexities of hypertension into a clear, shared set of actionable steps for both the nurse and the patient.